Hi, I'm Stephanie Shelton, and this is episode 28 of Conversations on Health, How We Get There. Lots of us became well acquainted with telemedicine during the pandemic, and while many of us have gone back to office visits with our doctors, telemedicine remains useful, especially for mental health issues. How useful? Well, a short time ago, I logged onto a fascinating Health Affairs Journal webinar on telemedicine. And with winter upon us, I thought it would make a timely episode. Joining me is Dr. Ateev Mehrotra. He's a practicing medical doctor, and he also has a Master of Public Health degree. He is the Walter H. Annenberg Distinguished Professor and Chair of the Department of Health Services, Policy and Practice at the Brown School of Public Health. His research focuses on delivery innovations and their impact on access, quality, and spending. Our interview was recorded earlier this month before the Trump administration takes office. Dr. Mehrotra, thank you so much for coming on the podcast. I really appreciate it.
It's my pleasure.
So we've been hearing a lot about telemedicine. It gets promoted to us a lot by some of the systems that we're in for healthcare. What exactly is it? How would you define telemedicine?
Yeah, sometimes it's interesting how the terminology you can get a little confusing. Telemedicine, telehealth, digital health, a lot of terms being thrown around.
Yeah.
In a broad way, I think of the telehealth or telemedicine as basically using technology as a way to connect a patient and a clinician. And that can come in many forms, from text messages to video visits, to phone calls, to monitoring programs, et cetera. Though most people, when we talk about telemedicine, and most Americans, they usually are thinking about one form of it, which is a video visit or a phone visit. And that's what I usually focus my attention on, because that's where we see the largest numbers.
Yeah, I used it once during the pandemic, and I just did a phone visit. And that to me wasn't telemedicine.
Why do you say that? Just because it didn't feel?
I didn't see the person. It didn't seem, I don't know, just didn't seem legit somehow.
Yeah, there is a funny thing, a little bit of a side tangent, but for decades, I've been calling my patients. Others have been calling their patients, and we used to call it a phone call.
Yeah.
And then during the pandemic, we relabeled it. It was all of a sudden a phone call turned into an audio only telemedicine visit, and largely because that facilitated payment.
Aha. So it was very much used during pandemic times, and maybe some of that from what you said at the Health Affairs meeting that I paid attention to has fallen off since then. But who were the people who used it the most, both people and doctors, and what basically was it used for? Did it really substitute for a substantive office visit?
Right. So what we see is that, as you alluded to, a big surge of video and phone visits early on in the pandemic, and then a subsequent decline since then. And we're about, roughly, best I can estimate, about 1 in 20 visits in the United States are still video and phone visits, sort of plateaued around there. But as you indicated, it's not kind of homogenous, like there's a variation. The biggest and most striking area of variation is in which clinicians and conditions. If we were to go into, I don't know, an orthopedic surgery practice or cancer care, it's very rare to see a telemedicine visit. Mm-hmm. However, if we were to go in the area of mental illness treatment, psychiatrists, psychologists, therapists, there you are seeing very high usage, maybe nearing 50%, and a large fraction of clinicians have gone fully telemedicine only and just given up their physical practice, about 15% or so. So you have this huge variation by which clinician you're talking about, and relatedly, which condition they are, or what medical problem are they addressing. You also ask the question of who on the patient side. And again, a lot of variation. We see maybe the most striking difference is urban rural, where the hope had been that we'd see more rural patients use it. Unfortunately, we see the opposite.
Hmm.
And there's probably a lot of things to unpack there, comfort with technology, availability of broadband, et cetera. But they're just on the numbers. Another aspect that I'm often asked is, how about age?
Yes.
Here it's kind of a little bit complicated and not what obviously people think. People usually go in to say, oh, it's just the youngins that are doing this because they love the technology and they use their smartphone all the time. But the issue is that as we get older, unfortunately, we need more healthcare. And so just in terms of doctor's visits, people who get older have a lot more doctor's visits. So if you actually look at the fraction of visits that are via telemedicine, fraction of telemedicine visits, it's usually older adults because they're just getting more healthcare. So that's a little bit more nuanced in the way as you think about it.
And I, from my own experience and from what my friends have told me, in countries where healthcare is completely covered for all, they're tired of having their waiting rooms clogged up with older people who just come in for like a little reassurance or, can I adjust my medication, and the things that could be easily done with a telemedicine or just a telephone visit. So perhaps if older people use it, and older people in a sense are getting younger because more younger people are turning 65 and bringing their skills that they've been using in work and life with them. As that continues to kind of turn over, you might find some of this routine stuff done without clogging up a doctor's office.
Yeah, so I'd say two reactions to your comment. The first is I would agree with you that there have been a lot of concerns, appropriate concerns, that many older adults aren't facile with the technology. Maybe because unfortunately, as we get older, some element of cognitive decline, but also just they didn't have a whole career using technology.
Yeah,
But as you alluded to, the wind is at our backs, that the 65-year-old of today is very different than the 65-year-old of 10 years ago and 20 years ago. And
exactly.
so in that sense, this is going to rapidly change just because of time and progress. The other component you raised was, just to unpack that a bit, was about waiting rooms and using up, and this would free up space a little bit. One of the issues that I think doesn't get enough attention is that telemedicine visits are using a technology to connect a patient and a clinician, as I said before. And in general, we kind of think it takes about the same amount of time on the clinician side. Why is that important, relevant to your comment? It's because it isn't prior to the pandemic, prior to our use of telemedicine, that there was all these clinicians out there twiddling their thumbs saying, gosh darn it, I really wish I had more time that I could take care of patients. No, they were slammed and there were long wait times, etc. So while yes, this allows the technology to, you don't have to leave your home, or I could see someone 100 miles away, it doesn't mean I have more time to manage patients. And so in a weird way, it hasn't really freed up access as people might have hoped. Unless we can start delivering the care more efficiently, we're still going to have the same issues of just shortages of time and capacity. And there's also, in a crazy, perverse and unintended way, it could make the problem worse. What do I mean by that? So right now, in 2024, so many Americans are struggling to get care for mental illness. And we talk a lot about this issue. And people think about telemedicine as being a potential solution for that, as a way to access more. And that certainly increases the pool of providers you can see. But what we see in the data is that if you took the patients that a psychologist was seeing, and now you got telemedicine. They move out of town. They're away on a trip. All of a sudden, they can continue to see their same psychologist. And so the fraction of new visit appointments for psychologists, psychiatrists, et cetera, went down,
Interesting.
not up, because people just kept on getting care because it was easier. And this is an example of, and I know this is a long-winded answer or response to your thumb, but it highlights how telemedicine, unless we really increase the amount of time that clinicians are caring for people, may not improve access in the way that some had envisioned.
Well, going on to the problems with telemedicine, I think it was you who talked about the fact that um, we have a mishmash of regulations in this country in terms of medicine, doctors, what kind of licenses they need, clinicians, nurse practitioners, so on and so on. And it's state centered. So if you do move to another state, and let's say that the person who's helping you with your mental health issues is a psychiatrist and can write prescriptions, maybe that person may not be able to write a prescription for you in your new state.
Yeah, this is a place where telemedicine has really brought to a head something that kind of was working okay for a long time. So, just to give a little background for all the listeners, um, the way that we have regulated the practice of medicine for, I don't know, about almost 100 years now, is that the clinician, psychiatrist, psychologist, physician has to be licensed in which the state in which the patient is located. Mm-hmm. Before, that was not a big deal. I live in the Boston area. If a patient came from New Hampshire to visit me, they were located in Massachusetts. I was licensed in Massachusetts. It was fine. Now, especially in places like New England, where we got all these little states, people are driving and all of a sudden, wait a minute, that patient from New Hampshire who just drove an hour or so to see me, now I am going to see them in their home in New Hampshire. Wait a minute, I'm not licensed in New Hampshire. And it's a pain in the butt and pretty costly for me to get licensed in New Hampshire. And then for me to get licensed in New Hampshire, Vermont, Rhode Island, Connecticut, Maine, New York, Pennsylvania, and for specialists who are getting patients from all over the place, a thing that was never part of their never part of an issue has now become a huge problem. And so, you might ask, why do states do it? Well, it's just sort of historical legend that not legend, historical legacy, excuse me, where that's the way we've done things. But the rise of telemedicine has really created a huge issue. And it's infuriating for a patient. So if I have a patient in New Hampshire and she calls me up and or she schedules an appointment, I can't take care of the patient in her home. But if she drives down the highway, pulls over at the rest area, and does a video visit from their car, that's okay.
That's crazy.
That doesn't make any sense. Patients are rightfully, and clinicians are rightfully frustrated because it doesn't make any sense. And, it's to the level of in the DC area, right? With Washington, DC, Maryland, and Virginia right there. Right. There are people who are like on, I don't know, channels saying that's a really good parking lot to have your video visit because people are where they're not going to be bothered because you were having a video visit with your, I don't know, psychologist and someone's knocking on your window, get out of town, leave our parking lot. So that's the level of, I think, rightfully idiocy that we're at right now. Insane. And so your question really just emphasized that. Are there ways to fix it? Of course there are, but they're going to take legislative action. And for a variety of reasons, which if you want to, we can get into, we haven't seen that much traction on this.
Well, I was going to raise this toward the end of the interview, but we're talking about it now, which is we're recording this before President Trump takes office, and along with whomever gets confirmed to head up the medical and health agencies in our government. And no matter what agency you look at, they're all being committed to cut, not add, regulation and personnel to enforce those regulations. So it's almost like it's a bad time politically when a new administration is coming in looking to cut red tape, and they would look at that and say, you want us to federally license doctors after all these years and all the states' rights stuff we really believe in? You got to be kidding. And that could be a main.
Yeah, well, I think, Stephanie, I think a little bit more complicated than that. So it doesn't need to be a federal license. I agree that the federal license in this climate may be seen, but it could be as simple as New Hampshire, the example I was using before, would have reciprocity, saying, look, New Hampshire could pass a law saying that if a doc from an adjoining state or any state who's licensed in good standing, no malpractice suits, wants to take care of a patient in our state, we're good with that. And during the pandemic, almost every state in the country passed temporary regs to do that. So it's not like unprecedented. Everyone did it. They just let those expire. And so that would solve the problem. I would say it very much like our driver's license. I have a license in Massachusetts. I drive to New York State. New York State and Massachusetts are in a compact saying that we acknowledge each other's driver's license. And if you get in trouble in New York, they'll tell Massachusetts and vice versa. You got to pass the law. You got to pass the rules. And so something like that would be very reasonable. Also, many of the issues I've described where telemedicine can be advantageous are particularly important for rural states where they have more of a shortage of clinicians. So given those states are differentially represented by Republicans, you could see there's a lot of attraction for moving forward on that. So that's why I think that this issue may not, there could be ways of overcoming this, which would not be about increasing regs. So that's just one thought. I'm not naive. I also acknowledge that abortion has a role in this because practicing across state lines has raised many people's concerns that that'll mean that a bunch of people will provide telemedicine facilitated abortions in my state. I think that's fiction, and that's not any such rule is going to facilitate that. But on the other hand, I think there is a little bit of a knee-jerk reaction. So I want to just acknowledge that there is that barrier politically.
If you talk about telemedicine, both from the standpoint of the convenience of both the doctor and the patient for certain situations, aren't you also, to some extent, then talking about perhaps, depending on whether it actually cuts down on office visits or not, saving some money? I have read that doctors bill differently. Some of them bill for full visits for telemedicine. Some of them discount it. But whatever, it would seem to me let's say if you see patients 5 days a week and some of that is telemedicine, you're still working, you're still billing for the service, but the room is free. The offices are free. You don't have to be there. Perhaps you could sublet out to somebody else who needs a office for a period of time, or just within the state and federally paid for healthcare, save some money. And might that not be attractive?
So I think you're raising a really critical point. The first thing I'll say is that the impact of telemedicine on spending is by far the most critical issue. Because if we're going to continue to pay for these, then we're going to need to find some place to pay for it in the current, at least on the federal side on the Medicare program. They want it to be budget neutral. So you got to find some a cost savings if it's going to increase spending.
Medicare is cutting blanket payments for telemedicine at the end of this year.
Well, at the end of this year, in I guess less than 3 weeks now, or a little bit more than 3 weeks, excuse me, as we're recording this, Medicare is scheduled to stop paying for telemedicine visits. There was what I saw a news story from yesterday or the day before where there's negotiations on as they term it, the pay for. How are you going to pay for this? I won't get into the details there, but the question that just to go back to is the issue is how much does telemedicine increase spending? If so, by how much? Our research finds that it does increase healthcare spending by not a lot, but in Medicare world, even a 1% to 2% increase in spending is a huge amount of money because it's such a large program. So now going to the question of why, a lot of it is driven by the fact that we currently pay for each telemedicine visit at the same rate as an in-person visit. And many states have passed laws mandating that. that says they're called telemedicine parity laws, that if you have a visit in person versus in telemedicine, it's got to be paid the same amount. And some have even argued that and passed legislation related to the phone calls. Um, the counter argument to paying at the
Can
same
I
rate is
just stop
exactly
you
what
for a
you described.
second? Is
Yeah.
is that coming from doctors or from the legislatures themselves?
I think it's mostly doctors saying, look, we want to be paid the same amount. It's the same amount of time for me. I think what you argued is the counter argument. Like, yes, it's the same 10 minutes, but you're doing it from home.
Yeah.
You don't have the same overhead. You don't have to pay, for that table with the crinkly paper on it and, the thing hanging on the wall and so forth. And those other costs, what we call practice expenses, are lower. I'm with you. I have advocated pretty aggressively that we should pay for telemedicine at a lower rate. Um, and that'll both help with the cost issues as well as I just think it's the right thing to do. But I won't deny, and as I've demonstrated, the clinical community disagrees with me. Many do, at least, and that's why you see some of these laws.
I want to pick up one thing before we move forward on this, which is when we were talking about who uses telemedicine and who doesn't or didn't. Um, can we break it down even further between old and young to men and women and also various races?
Yes. So men and women, the women on average in the United States receive more health care than men do. So women get more more likely have received a telemedicine visit. So that's one just aspect of it. In terms of race and ethnicity, there it gets a little complicated. So I'll just try to unpack it. If you were to look across the United States and say who's more likely to have received a telemedicine, Blacks, Hispanics, historically underrepresented groups are more likely to have received a telemedicine visit than non-Hispanic whites.
Interesting.
Whoa, why is that the case? Well, if you see communities in areas of the country where we have higher telemedicine use, so let's take the West Coast, the Southwest, uh, um, maybe in particular, those are areas of the country that we see a lot of telemedicine use per capita compared to, say, the upper Midwest, our North Dakota, South Dakota, Montana, et cetera, just as an example. So because Hispanic Americans are more likely to live in the Southwest, you see greater use. However, and where it gets complicated and nuanced is that within those communities, we see the opposite. That within say, a San Diego, I'm just using that as an example, you're going to see that in that community, Black and Hispanic patients are less likely to receive it than non-Hispanic whites. So complicated.
Well, that could complicate how much use it gets, how much the federal government is willing to pay for it, and that kind of thing. Except, again, it seems to me the goal of healthcare, period, in this country, which does not cover everybody, is to spread at least basic coverage to all the people who now don't get it for one reason or another. People who don't know they're eligible for it with Medicaid, for example, or they're just buried in a city somewhere and they've heard stories handed down about bad experiences with doctors or whole societal bad experiences with the medical system. And it seems to me that telemedicine is a way of extending at least some of that healthcare, pulling people in and getting them used to the idea. And then maybe they'll be willing to go to a doctor or to a hospital for something more complicated.
Yeah, there have been, I don't know if people have pursued it exactly how you've done it, described it, but there has been some thought that maybe telemedicine and just the convenience of it can keep people engaged in care more effectively. I might give like one example that I heard a lot about was in the airline industry. employees are all over the place all the time. And
Hmm.
it's hard, I imagine, as a, I don't know, a pilot to continue your care when you're in one town versus the other town there. And so you could see a very different way of receiving care if you have a telemedicine only primary care practice. So you and I have one of those now. When my primary care clinician, the usual way I reach them is through a video visit, and that's very convenient because I can go anywhere and just get a visit that way. And so the idea, sort of similar to what you're describing, is that if I'm engaged in care, I have that access. Next time I'm sick, I'll get the care before I have to get really severe before I go to the hospital. That's the hope.
Well, and I suppose the other side of that is you do like sitting across from your doctor and having him or her reassure you that it's going to be okay, pat the little kid on the head. And that you can't get that in a telemedicine visit. You can say it, but you're not physically present to touch somebody. And that
Yeah. I
touch
have
can
kind of
mean so
mixed
much.
feelings on that a little bit, Stephanie. So I'll just kind of first, I just want to acknowledge that in our own work in national surveys of Americans, they say exactly what you said. Though, and asked, what would you rather have, a video visit or an in-person visit? They always say, I'd rather have an in-person visit, both because of the physical exam in particular, but also just being in person feels very different and a better experience. We've also heard from people, maybe sort of similar to what you described before in this we were talking, which is like a phone call doesn't seem like a real visit. Come on, and so there's that aspect of it. But I'm also, and the thing that's hard to measure, will only time will tell, is this just also all of us just having a bit of resistance to change? Like if you were to ask people, like, do you like going to see your bank teller? And, I used to go with my mom and dad, and we'd go visit. We knew the bank teller. We'd always have that interaction. I got a lollipop. It was really nice as a kid. But if you ask my parents, would you like to see a bank teller versus an ATM? They'd be like, oh, I love seeing the bank teller. But when it came down to it, we switched pretty quickly to ATMs and now online banking because it was more convenient. And so, as much as we loved our bank teller, we ditched her really quickly when it came more convenient. And so that's the part that I often don't know about. So I think we would all prefer the in-person visit, but if it's that much more convenient, will we vote with our, I guess, our mouses, if you want to say it that way, and get a video visit? And maybe over time, 10 years from now, most Americans will be like, oh, yeah, no problem. I'll do the video visit. It's no big deal.
I'm kind of thinking of it more for the simpler things, the things that you now sit down with a nurse practitioner for and talk to on a routine checkup rather than, and I don't mean blood tests and stuff where you've got to be there in person, but a lot of stuff is done. I have a yearly checkup for something where I rarely see the surgeon who did the surgery. I see his nurse practitioner, and she's just fine. And I don't mind not talking to the doctor, and that's it. It's just routine. But if there was something important that came up, then I think I would want to talk to the doctor in person. So for the routine things, for like digital monitoring, so many people now have digital devices to monitor, particularly diabetes, for example, but also heart issues. Um, that can be done by a televisit. A lot of times they check the batteries or whatever on a device. That's all done by phone, basically, anyhow. So that kind of thing, which might improve compliance, if nothing else.
Yeah. No, I think that in some of our work, we find that telemedicine is associated, for example, with improved medication adherence. Not a huge amount, but the thought process, at least I have, is that, it gives more opportunities to touch base. Hey, Stephanie, are you still taking that med? What's going on? Let me talk to you about it. So those more frequent opportunities to connect are also important. Um, and it's, so I want to acknowledge that there are some benefits societally. But I do want to go back to a point, which is not all doctor's visits are helpful, as much as that pains me to say. But, I think in many cases, if I see a patient in office, I can diagnose, manage, treat, make an improvement in their care. But I also just want to acknowledge that a lot of visits may not be critical. I don't know anything about your own circumstance, but at least in my clinical experience, sometimes people come in for a yearly visit, and I'm not sure why we're having a yearly visit, and if you have telemedicine, people are going to more likely show up for that yearly visit, even though they are kind of like, this is really needed. And if you really push the clinician, they might be like, well, it's probably okay. We can go 2 years or something like that. So there is this aspect of it. The way we frame it in our health policy world is the value of the visit. Is it high value or low value? High value means that you get some clinical benefit for the cost, and low value means you don't get any clinical benefit from the cost. And when we use telemedicine, we're increasing both the high value and the low value applications. And so that's the issue that we kind of need to navigate there a little bit when we see this increase in spending and visits.
Let's talk a little bit about the downside of telemedicine. And I think you brought this up, which is basically during the pandemic, there was an issue with prescriptions, too easy to prescribe narcotic medication, the drugs that we're having problems with. And again, if you're talking about cross-border, and licensing and other or acknowledging licenses across borders. How with telemedicine are you actually going to deal with a prescription issue?
Right. So if you don't mind, Stephanie, I'll just take one thing I want to say, and then I'll get to your question in just 2 seconds. I want to first say that when I talk to most Americans, one of the concerns is, am I going to get the same quality of care on a video visit or a phone call than I am going to get in person? And my response is that the research generally showed yes. It's just on a larger, high-level quality side than what we observe in the data. There are exceptions, and I want to acknowledge those exceptions where it's inferior, but as a whole, it's okay. Now, you raised this question of a specific issue of prescribing, and it's about prescribing inappropriately, and that maybe telemedicine could make that easier. You have a
inappropriately, and also I myself have had situations where I need to renew a prescription, and it's routine. It used to be routine, and now the doctor will say, "I'm not going to renew it until I see you."
Oh, I see. Yeah, so that I think one unintended and I think negative consequences that you could see more inappropriate visits that you don't need to because you could just follow up. And I think that is an issue. And that goes back to that value thing. Are you having a high value versus low value? The other thing that I've brought up before is that there have been early on in the pandemic, when more and more Americans were using telemedicine, a large number of private companies said, hey, we want in. They started telemedicine only companies that would treat, you name it, they'll got it. And you can probably find it on the web from, I don't know, colds to mental illness to menopause to acne, whatever you say. The problem is there probably is a telemedicine company that says, we got that for you. These companies used a very Silicon Valley model of getting VC or venture capital funding with the idea of growing rapidly and expanding and kind of capturing that space. There has been concerns that these specific companies have been, at least some of them, having a growth and strategy that's sacrificing quality. And there have been a couple of examples, including CEOs have been arrested for inappropriately prescribing, for example, ADHD meds or stimulants, and just, some has described it pill mills. So that was one area when you were talking about prescriptions across state lines and so forth, where I do think there is a legitimate concern. I don't want to pretend that all of those companies are doing this. I think they are the exception that are doing this, but it does telemedicine and the fact that I can all of a sudden start up something and see patient in every state very, very, very quickly makes it a little bit easier for me to do so. And so I do think we need to be watching those specific areas pretty carefully, in particular with dangerous meds or scheduled medications, as we call them.
So going forward now, just looking ahead without, any knowledge of the Trump administration and what their regulations are going to be or not going to be, or even beyond, where do you see telemedicine in 5 years, in 10 years?
So I always the reason I did the big sigh there was just because I
Big
think
question.
it's a very reasonable question, and I think the listeners want to know. On the other hand, I also just I've been burned enough times to know that I probably don't I don't I have a better crystal ball than anybody else. But I guess I'll just give you my some quick thoughts. My view is that when we talk about telehealth or telemedicine 5, 10 years from now, talk to the average doc or patient or American, they're going to be less focused on the video visits and the phone calls.
Hmm.
While video visits and phone calls are fine and they have some benefits, they they're sort of the same thing. It's kind of trying to replicate what we were doing in person using technology. And I think where I get more excited is about when we use technology to deliver care in a fundamentally new way and potentially better way. Let me try to make that a bit more concrete than just airy language. One of the things you mentioned was digital devices. I think a lot about remote monitoring. There, to make that even more concrete, you have high blood pressure. I give you this device, say, go home, check your blood pressure every day through a Bluetooth enabled device or via cellular. It's going to come to me every day. Just check it every day. I'll remind you if you don't do it. And I'll be watching. If the blood pressure is going low for a couple of days, I'll call you up and say, hey, Stephanie, what's going on? Let me adjust your meds. Oh, the blood pressure high. What happened that day? Oh, you missed your meds. Okay, let's make sure we don't have that. And so what's happening is we've switched from a reactive model, which is the norm in healthcare, which is I wait for the patient to get sick to put their hands up and say, hey, I need some help,
Right.
to a more proactive model, which is I'm watching and I'm helping and I'm supporting, and you can go on and live your life if everything's going hunky dory. Why does that make me more excited? One, I think I can actually make a bigger difference in terms of people's care. And for example, the example I provided was high blood pressure. It's more convenient, and ideally, I'm going to lead to better outcomes. So those forms of telehealth, I don't know, apps on your phone, other things, I think are probably going to have more improvements in healthcare at a lower cost, and therefore probably are going to have more traction than our video visits and phone calls.
Well, now we're talking about preventative medicine, which is the goal, anyhow, in a sense, that first of all, you don't want people to get sick with easily preventable um, situations, diseases that are easily preventable, like those caused by obesity and all of that. And that's the whole thing about, the obesity drugs and paying the money up front, so they don't get heart conditions and cost a lot more 20 years down the road. But my way of looking at it as a patient and also just as a journalist, because I've just seen so many people in different circumstances, is if you can do what you're saying, which is basically preventing, if you've already got something, preventing it from getting worse because you're monitoring it. And nobody's going to come into the office enough times, and nobody's going to allow you to bill enough times, no insurance company, um, to get that kind of compliance. And also, if you have a patient on the edge of something, they haven't got it yet, um, like you've got high blood sugar, but it isn't at the level of diabetes. It's not quite at pre-diabetes, but it's getting there. You might be able to monitor them, prescription or not, simply by this method. And the attention alone might keep the disease from developing. And then isn't that the gold standard that we all want, basically? We don't want to
Yeah,
put you
and
out
I
of
think diabetes is a good
business.
example. Like you might see more and more people with those little white things on their arm where people are doing continuous glucose
Right.
monitoring. And that's a good example. Also, kind of similar with prediabetes. You might have a person with prediabetes. You might say, let's try this device. Now you can buy them over the counter, which is nice.
Right.
They're getting cheaper. And so we'll monitor that. I'll get the data and both feedback to you as the patient and feedback to me as the doc. I can kind of say, hey, and maybe through diet and exercise alone, we can prevent the need for any medication. So that's just an example of that.
All right. So, is that so your vision of telehealth is basically a monitoring and keeping up with a patient in that respect, more than using it for standard kinds of visits. Is that clear?
Yeah, a little bit of just revisiting the way we take care of medical problems in that way. And I gave the example of chronic illness. Just to, in terms of where we're talking about let's just take another example where substance use disorder, opioid use disorder. A lot of patients, unfortunately, in the United States have a opioid use disorder to either heroin, fentanyl, synthetic opioids. We have a lot of treatments for them, but it's often based on come into our office therapy, medications will provide, buprenorphine in particular. But we can support people in other ways. And so there has been other forms of telehealth that have been introduced with apps that help support people, AI chatbots that are your friend and your support group, not to replace those other things, but to create a more cohesive package that really supports people throughout that. So when people are thinking about I think about those things of telehealth as being really ways to improve the quality that we can provide in that way. So that's just another example and I don't know if it fits into the idea you were talking about preventive care or not, but that's just another way of how we can use technology or telehealth to improve the model of care we have. And let's be clear, unfortunately, most people with opioid use disorder have relapses. So we need anything we can to try to keep them in care as long as possible.
I think what you're describing is almost like a branch of social media. Um, Particularly if you're young, you go on your favorite social media platform, sometimes for reassurance from your friends or just to discuss a problem with your friends. Um, it's kind of like this monitoring becomes part of that system that you're already used to, certainly if you're younger. And even older people who use just Facebook, for example, that's what they're doing. They're talking to their friends who might be all over the world or all over the country through Facebook. And you're just adding that into the mix, it seems to me, by this kind of a description. Yes, you've got to have a doctor on the other end of it, or a nurse practitioner or something similar. Um, but it's a world that younger people have grown up with, might be more receptive to as time goes on and this becomes more normal, and might ultimately prevent a lot of bad things.
Yeah.
Anyhow, I see
And
it that
yeah,
way.
I think I'm with you in sort of the vision that you're describing. Mostly, the only thing I might just add one aspect of this, which is that when do you need that physician and nurse practitioner on the other side, and when do you not? I think there has been some interesting work on some of these large language models and their diagnostic accuracy, et cetera. So I don't think we're at the point where we would ever do so right now, but I think in the future we might be at a place where you can do so.
Okay, last question. So you can think about this all you want, but the reality is that Medicare is stopping its payment for telehealth except in certain mental health situations or rural situations. And what Medicare does, often private insurance follows. So what are you going to do about money in the interim?
Yeah. I think that it's December 6th. As we said before, December 31st, things are going to expire. I've been told by many people that there is going to be a short-term 2 to 3 year extension of these policies because there is such bipartisan support and no one wants to tell the American public that we just took your telemedicine away.
Hmm.
Um, but and so my expectation is maybe at the last second, we'll see some legislation that pushes this down. And so I would be very, very surprised if we don't see that. Again, just Well, Americans have not flocked to telemedicine in huge numbers. They do want it to be around.
All right. Any final thoughts on this?
I don't think so. We've covered quite a bit of ground here, Stephanie. So thanks again for including me on the podcast.
Well, thank you for coming on and for your font of knowledge and speaking it in, simple terms that we non-clinicians can understand. Dr. Ateev Mehrotra is a practicing medical doctor and also has a Master of Public Health degree. Dr. Mehrotra is the Walter H. Annenberg Distinguished Professor and Chair of the Department of Health Services Policy and Practice at the Brown School of Public Health. There's more in the show notes and a link to his latest research paper on telemedicine, written with colleagues, which appeared in a recent edition of Health Affairs Journal. Seems rather amazing to me, but the podcast is now in its third season, and episode 29 will mark the fourth calendar year attached to its name. Appropriately for a new year, we're going to be talking about women's health with a renowned New York endocrinologist and gynecologist, Dr. Michelle Warren. 2.5 years after the Supreme Court's Dobbs decision on abortion changed everything. As you probably know by now, I schedule just one new episode each month, so look for episode 29 on the third Tuesday of January. Updates on my podcast page, and I'd really appreciate it if you'd subscribe and, of course, share. We're on Apple, YouTube Music, Spotify, TuneIn, Amazon Music, iHeart, Podchaser, and my host platform, the Podbeam app. The video version is on YouTube. Show notes and links on my website, www.stephanieshelton.com/conversations. If you like the podcast, please tell your friends and leave a review or give us a rating wherever you watch or listen to your podcast. I'm Stephanie Shelton, and until I see you again, please take care of yourself and all those you love. Conversations on Health, How We Get There is produced and edited by Frank Harold. Research assistance from Dr. Richard Saltman, Professor Emeritus of Health Policy and Management, Rollins School of Public Health at Emory University in Atlanta.